So we start for the presentation for the oral presentations. And this is my student information. My name is Zhu Chen, and my student number is 2217098. And for today's presentation, it's composed of three parts. The first part is for HE assessment technique for your scenario. The second part is for 4 hour senior certificate for stroke prevention. And the third final part is your pre-medication and discounting the consideration. We come to the part 1.2 assessment. So right now we have a patient for Mrs. Mayo, and she so for her age is there with this patient, and she has a slur speech, and for the GCS is 12, and for I is 4, verbal is 3, and for is 5. And she has a risk of exploration test. And for his breathing part, his respiratory rhythm is 26 BPM, which is a little bit inconvenient, and his breathing down is shallow. And his oxygen saturation is 95%, greater than mass of critical oxygen. And she also has a bilateral air entry equal, but reduced advantages. And for his C is circulation. Her heart rate is 176 beats per minute, when his blood pressure is 139. And she also have a categorically forward betting or if not on his feet. And capillary refill is less than 14%. And his disability, she has a left facial gut situation, and she also has a left-sided hematopoiesis. And following commands with his, he can follow the commands with his right side, which is normal. And for his people with equal and reactive command. And for his exposure, he is febrile and no wounds and bleeding. And he also has an intravenous annular incision at his left cursor and mild pedal or edema. The BGL is normal, and height and weight according to the BMI. She is a little bit obese. And so we think in conclusion is that Mr. Mayo presents with classical embolic stroke findings, breathing conscientiousness, left side weakness, and disarrhythmias. For the secondary cardiovascular instability, mainly because of he has a AF situations. And second part, I will to mainly talk about for 4 high priority nursing interventions. So the first one I want to mention is about we should activate the stroke protocol and arrange urgent neuroimaging. So what our should do is to immediately initiate the hospital stroke call and record the last known whelm time and coordinate a contrast CT scans to exclude potential hemorrhage risk. And then it should be rapid imaging within the 4.5 hours therapeutic window determines eligibility for intravenous thrombolysis and endovascular thrombectomies. Some scientific research says that timely activation shortens clock to natal times and improves function recovery for patients. And technically, I want to mention is about maintain airway safety and continuous neurological monitoring. So because Mrs. Milo, she has a GCS of 12, it's a little bit declining for normal levels. And also she has a slurred speech. So airway protection, I think, is very in high priorities. And positioning her in a semi or high flowers positions provides her oxygen at 6 little per kilogram and preparing such equipment to reducing exploration risk. And continuously neural observation, assessing like GCS, pupils, and her limbic strength will be enable early detection of deterioration and guide escalation to the rapid response team. And the third thing we should keep in mind is for control his physiological parameters like the oxygenations, glucose, and body temperature. But before intravenous thrombolysis, SPP should be less than 185, and DPP should be less than 120, and it also should be remained at a level at 118 and 105. And for oxygen saturation should be maintained over 94%. with normal glycemia and normal uremia to prevent secondary brain injury for patients. So evidence also shows that targeted control of these parameters will lower the risk of hemorrhagic transformations and improve cerebral perfusions. And final thing I want to emphasize is that we need to prevent aspiration and the venous thromboembolism and also communicate with his family on time. The patient should be remain now by mouth until swallowing screening is completed. And appropriate aspiration precaution and oral care reduce the pneumonia risk. If the patient is immobile, intermittent, pneumatic, and compression by IPC devices, with family members about the care will be devices will be provide effectively DVT prophylaxis and clear empathetic communication with family members sometimes about the patient's their goals and treatment options will enhances understanding and support the whole medical patient and medical staff their whole shared decision making it will be more beneficial for patients. And in third part, I'll be mainly talking about the pre-medication and their negative inspiration for stroke patients. So the first one is for IV actually place is TVA. So before giving this drug, we should be confirmed that symptom onset is within lower than 4.5 hours, and CT imaging shows no hemorrhage. BP must be below even 185 and slash 110. And the end coagulation profile, glucose levels, and recent surgical history should be reviewed for the patient. And a standard dosage is 19 milligrams per kilo, maximum is 90 milligrams. Within 10% given as a RV bolus followed by a 30-minute infusion. During and after infusion, maintain continuous blood pressure and neurological observation is very important for the patient. And withholding anti-thrombotics for 24 hours and withholding for antiplatelets is also a key part. And then the main adverse effect for TPA is about intracranial and systematic bleeding, and early signs also including for newly headaches for the patient and neurological function decline and severe hypertension. And second drug I want to mention about is for heparin IV infusion. So systematic heparin is a classical anticoagulate agent. So systematic anticoagulation is now routinely recommended in acute ischemic stroke to improve outcome. The may prescribe for arterial fibrillation prophylaxis. Baseline, we should be measure their APCT, platelet count, and also about their renal function should be assessed. If we order heparin, administer via infusion pump using a dedicated line and adjust the rate according to ABDT targets. So heparin also have some side effect, which is bleeding. So we can see patiently have many bruises on their skin with a running bleeding nose. So if patiently suffer from neurological worsening, that might indicate intracranial hemorrhage. And heparin-induced thrombocytopenias (HIT) is also a severe complication requiring intermittent sessions. The final thing is for metoprolol, 550 milligrams of PV. And metoprolol controls the ventricular rate in AF patients and assess baseline heart rate, blood pressure, and signs of a heart failure before administration. And the usual oral dose is for 50 milligrams twice daily. If given intravenously, easy to monitor is also very important. And if we observe patiently suffer from hypotension, bradycardia, or fatigue, usually should be considered like overdosage used for metoprolol. And the drug may cause hypoglycemic symptoms in diabetic patients, and therapy should be withheld if like heart rate is less than 50 and SBP is lower 90 milligrams. So here is my reference. And finally, thank you for your attention for my presentations. That's it.